nasopharyngeal cancer, the other one being angiofibroma. So any presentation of angiofibroma comes with a rapid unprovoked bleeding, okay? Usually seen in the juvenile age group, maybe at the age of 12, 16, 18, max 20, okay? But on contrary to nasopharyngeal cancer, usually seen in Chinese population and elderly age group, about 50 to 60s, okay? So we'll be discussing the same here. Before starting about the tumor of the nasopharynx, I'd like to discuss the anatomy of the nasopharynx, okay? So whenever we talk about the anatomy of the nasopharynx, we can see anteriorly what we have is the nasal cavity. So this is the nasal cavity. And superiorly you have the sinus of Morgagni. Okay, I'll tell you about the sinus of Morgagni. At the back side you'll have this prevertebral fascia, and lower side you'll have your soft palate, which actually opens from the oropharynx. Okay, anteriorly you have this tongue area, your oral cavity. So usually when we talk about pediatric age group, so it's rhabdomyosarcoma, lymphoma, and a different contrary is juvenile nasopharyngeal angiofibroma, right? So the most common nasopharyngeal tumor, which is malignant, is actually nasopharyngeal cancer. So it's seen in Chinese population, as I already told you. Now there's actually a hypothesis that why in Chinese population, it's because of the nitrosamines component which is seen in the dry salted fish, okay? And similarly, on contrary, whenever we talk about stomach cancer, which is more common to Japanese population, nasopharynx is more common to Chinese population, right? And the male preponderance is 3:1. And a small peak is seen in 12 to 18 years, and a large peak is 50 to 60 years. So we can actually see it's a bipolar age distribution, but more commonly towards the more side is the adult age group, okay? So we have three findings: the proliferative, ulcerative, and the infiltrative type. That's the gross morphology. But whenever we talk about the histology, in the histology, it's 85% it's squamous cell carcinoma, and 10% lymphomas, and 5% mixed type. The same presentation, about 85% of squamous cell carcinoma, it's the same presentation in the case of malignancies of your paranasal sinus. Okay, in the paranasal sinus also is most common squamous cell carcinoma. There are other carcinomas also in the nasopharyngeal area, like adenocarcinoma, but the most common being squamous cell carcinoma. Now let's talk about the different etiology. As I already told you about the genetic aspect, which is the sinus population, and HLA gene is also involved. Okay, HLA-A2 and HLA-B2. The other one being the Epstein-Barr virus. So just correlate. Okay, human papillomavirus responsible for CIN, cerebral intraepithelial neoplasia. Okay, Epstein-Barr virus, nasopharyngeal cancer. Okay, and also virus association might be seen in different other type of viruses. Okay, different type of other cancers. So here it's Epstein-Barr virus. On contrary, you can just memorize HPV. It's this one. It's your tumor of the cervix, as well as the tumor of the paranasal sinus also, human papillomavirus. Okay, it's the same. So contrarily, you can study that to memorize. Environmental factors, it's more common to exposure to nitrosamine, like dry salted fish, polycyclic hydrocarbons. That means the agarbatti, or basically you can say, which we light it in our houses, okay, in temples. More common to that, smoking, poor ventilation, nasal infection. These are all the environmental. But the major one being the dry salted fish. Never miss this one. The next one is actually the WHO classification. It's keratinizing, non-keratinizing, and anaplastic type. Non-keratinizing and the anaplastic type is divided into with lymphoid stroma, without lymphoid stroma. Okay, and remember that nasopharyngeal cancer is highly radiosensitive. So surgery is a late stage component of nasopharyngeal cancer. The first treatment modality will be radiotherapy. Okay, it is a very radiosensitive tumor. So I already discussed about anatomy. We can see the vertebral also, or little component, C1, C2 component involving the nasopharyngeal area. And this was the fossa of those above. Now this is important because above to the nasopharyngeal, this space, okay, this is the nasopharyngeal space. And above here you have this eustachian tube. and above here you have the base of skull. And the thing that I was talking about is the sinus of Morgagni. It's actually a potential space. It's a space in between your muscles of the pharynx and the skull base. Okay, the skull base and the muscles of the pharynx, they're not too much tight. Like I mean to say, there's spaces in between these areas. Like middle constrictor and inferior constrictor, there's a space. Skull base and the superior constrictor, there's a space. Skull base and superior constrictor, the space is known as sinus of Morgagni. And when the nasopharyngeal tumor, it involves that sinus of Morgagni, it is known as sinus of Morgagni syndrome, which presents like, which is actually total stripe, which we'll be talking about in the upcoming slides. So here you have three muscles, three longitudinal muscles and three circular muscles. Circular muscles is responsible for constriction. Longitudinal muscles are responsible for dilatation. So superior constrictor, middle constrictor, and inferior constrictor are the circular muscles, whereas salpingopharyngeus, palatopharyngeus, and stylopharyngeus are actually longitudinal muscles. So they arise from the eustachian tube, the palate, and the stylid process respectively. Salpingo from the eustachian tube, salpingo meaning tube, like your salpingo, whenever you talk about the fallopian tube, you just say salpingo tube, right? So here also salpingo means tube. So that tube is actually your eustachian tube, right? Palatopharyngeus means it arises from the palate and goes to the pharynx, and stylopharyngeus from the stylid process, okay? So these are the longitudinal muscles which are responsible for dilatation of the pharynx, okay? So this diagram, this skull base diagram is very important because nasopharynx arises from this area, and this area is actually known as the foramen lacer. This is the foramen oval, okay? And here you have your jugular foramen also. So this jugular foramen, if it's involving, then it's involving the 9, 10, 11, 12 cranial nerves. When it's involving the foramen lacer, foramen oval, it is involving the nerves that is supplying the Hereditary area. And majorly important is your orbit, okay? So it can involve the 2, 3, 4, 5 cranial nerve, okay, 5, 6. Also, if it involves the 5th cranial nerve, presentation will be palatal paralysis, okay? If it involves the 6th cranial nerve, then the presentation will be lateral rectus palsy. Now, more on this we'll be talking about in ophthalmology, okay? Basically, in the chapter of squint. So, just to sharpen your knowledge on squint, whenever we talk about lateral rectus palsy, right? So, in your eyes, suppose here and here. Okay, so this is towards my medial aspect. You have the medial rectus. Towards my lateral aspect, you have the lateral rectus, right? So wherever your eye is, the lateral rectus has been involved. Suppose there was a nasopharyngeal tumor and the lateral rectus has been involved. There's a palsy of the lateral rectus. So the pull of the medial rectus will be more compared to the pull of the lateral rectus. That is why the patient will present with esotropia. Okay, the person will present with esotropia. And since at this side, it's very difficult to visualize. So I was able to visualize the temporal side. So my face will be turning towards the affected side, right? So to look at this area, because I have an ESO, okay? This is a component of a paralytic squint, better to learn in your ophthalmology. But here it's basically your lateral rectus is being paralyzed, or it might be a paralytic paralysis. It might be a total ophthalmoplegia. Person may be totally blind, okay? Because the nerves are basically involved, okay? Now, so what is the most common presentation? So if someone asks you that, okay, the most common presentation, is it ophthalmoplegia? Is it the involvement of the hypoglossal nerve? Is it the involvement of your vagus nerve? So the person may actually, the nasopharyngeal case may present as hoarseness of voice also. So any person with a mass in the nasopharynx and hoarseness of voice, you have to think, okay, sometimes, because 10th cranial nerve, vagus nerve is also being involved, right? So person may actually present with hoarseness of voice. So the next pharynx is the most important presentation because it's highly, this area is highly supplied. The nasopharyngeal area is highly lymphoid rich. So at this particular area, what happens is there will be a posterior triangle involvement, posterior triangle lymph node involvement, and that leads to the posterior triangle dilatation, which is known as a Rovier's sign. Okay, Rovier's sign, same thing. ROUVIERES, okay, Rovier's sign. And if it's involving the deep cervical lymph nodes, it can actually involve deep cervical lymph nodes also. And when it involves the deep cervical lymph nodes, then that it can present as the upper dilated deep cervical lymph nodes, right? Nasally it can actually involve the area here, and it can lead to epistaxis, nasal bleed, nasal discharge, and ontological signs like collective deafness. Why? Because as I already showed you here, above the nasopharyngeal constrictor muscles, you have your eustachian tube, and if it's involved, then that can lead to conductive hearing loss. So your nasopharynx is a lateralized structure, right? Midline structure is an adenoid. So any midline structure, adenoid, when it hypertrophies, in the case of adenoid hypertrophy, it will lead to bilateral otitis media with effusion, usually seen in children, right? But here, since it's a lateralized structure, the conductive deafness will be unilateral. So, ophthalmoplegia, diplopia, ophthalmoplegia involvement of the 3, 4, 5 cranial nerves. It can lead to blindness if it involves carcinoma 2. Okay, proptosis may be there, jugular foramen syndrome may be there, 9, 10, 11, and also remember Horner's syndrome. So, patient may present with hoarseness of voice, Horner's syndrome, mass in the nasopharynx. Okay, that can also be the triangle. Patient will of course present with a mass in the triangle. Either that can be upper deep cervical lymph nodes, or it can be posterior triangle. Okay, so this is the most common presentation: upper and middle deep cervical lymph nodes and posterior triangle lymph nodes. And secondly, the person can present with headache if in case this is pelvis invasion. And for this, to rule out this, you have to go for an MRI. Okay. And total striate conductive deafness because of eustachian tube blockage, right? And it can be an ipsilateral temporal parietal neuralgia, trigeminal damage. It can be ipsilateral paralysis because of vagus damage. Okay, vagus damage. So ipsilateral temporoparietal neuralgia, trigeminal damage, and parietal paralysis. So you can remember this by mnemonics of NPC. Okay, NPC is nasopharyngeal cancer, and NPC is also totostriate. N is neuralgia. What neuralgia? Temporoparatal neuralgia. P is palatal paralysis, and that is because of the vagus nerve damage. And C is your conductive hearing loss. Okay, so NPC. And here its distance next to bone, lungs, and liver. So you can see the most common presentation: neck swelling, ptosis and adduction palsy, proptosis. This explains all about the presentation. So it can actually involve the nose, causing nasal obstruction, epistaxis, and proptosis. Distant met, very late presentation, liver long bone involvement, right? Eustachian tube, serous media, unilateral, cervical lymph nodes, upper jugular and posterior triangular lymph nodes enlargement, neck pain and stiffness, retropharyngeal nerves involvement, parapharyngeal space involving the cranial nerves 9, 10, 11, 12, and Horner's syndrome, cervical muscles involvement leading to trismus, right? Ophthalmological symptoms, right? So how can you go for an investigation? So what is the investigation that we can offer? You can just go for a simple OPD basis nasopharyngeal endoscopy. Okay, just go for a nasopharyngeal endoscopy. Just look at the size of the nasopharynx. Go for a examination in the OPD itself. Now, if it's not clear and if it's difficult to understand, you can of course go for a CT scan, right? So you can go for a CT scan. You can look into the areas involved. Okay, if in case surrounding eye or surrounding areas of the brain is involved, you can look into that way. But more precise for the brain is MRI. Okay. You can also go for a biopsy. Okay, biopsy is a very good method to understand, to look at the tumor of the nasopharynx. Now, if there is a nasopharyngeal cancer-like features, but you are not able to see any kind of mass, then you can just go for blind biopsy of the nasopharynx. Okay, sometimes there might be a very small mass which is not visible on endoscopy, but there's actually a mass, and patient has presented with symptoms, with features of that of a nasopharyngeal cancer, then you can just go for a simple type of blind biopsy. Okay, so nasophryngoscopy can be done. Tumor mass can be seen in the nasopharynx, which is seen in fossa prosingola, as I already explained in the previous slides. Nasopharyngeal tumor biopsy, if it's seen, then it's seen on blind biopsy. You can go for FNSC of the neck nodes, right? The first initial presentation is lymph node involvement, right? The CT of head and neck can be seen to see skull-base erosion, to see your head and neck, of course, ophthalmologic, of course, eye involvement can also be seen, right? And MRI head and neck can be done. MRI head and neck for intracranial extension, and you can also go for PET scan, photo immersion tomography, which is the very latest investigation, right? And serological tests. Serological tests can also be done. Here you have the more specific and more sensitive also serological test. Okay, immunofluorescence for IgA antibodies to viral capsid antigen, IgG antibodies for early detection, and antibody dependent cellular cytology assay. Okay, then just remember about cellular cytology. Now this is the nasopharyngeal that we have studied. Okay, so you can see we are looking at the fossa of Rosenmuller, right? So we are looking at the fossa of Rosenmuller. This is a eustachian tube opening over here, eustachian tube opening. So this is a tumor which you can see, which is arising from the fossa of Rosenmuller side. So okay. So this is CT scan, look, neck nose involvement. Okay, MRI, bone scan, CT. And if it's involved with the liver, bone, we can just look at bone scan, right? Mets component of TNM staging is very important. Okay, so TNM staging you can go for T1, T2, T3, T4. Now T1, T2, T3, T4 is actually T1 means just okay, just learn with me like this. T1, T2, T3, T4. Okay, so if it's just limited to nasopharynx, it's T1. Okay, 2 means just go 2, just make opposite of 2. It looks like an S, right? So it's soft tissue involvement. 3 is the involvement of the PNS. 3 is a 3-letter word, PNS, PNS. Okay, and 4 is it's the intracranial orbital involvement. Similarly, the neck node is also the same. Okay, N0 means no neck node involvement. N1 means neck node is involved, but the unilateral is seen in the supraclavicular fossa. I will show you all the things in this slide. Just understand for now. N1 means unilateral involvement, neck nodes. Okay. N2 means bilateral. N2 means bilateral, both sides involvement. N3 means more than 6 centimeter size. More than 6 centimeter size, maybe unilateral, maybe bilateral. Anything more than 6 centimeter size. For Mets, you have M0 and M1. M0 means no Mets, M1 means there is a Mets. Okay, so you can see here T classification: T1, T2, T3, T4. T1 is nasopharynx, T2 means soft tissue. So soft tissue means it can be area of the oropharynx, nasal cavity, or the parapharyngeal space. Okay, and T3 means involvement of bony structures of the PNS, 3 skeletal structures. And of course, you know that this PNS is actually very much includes compartment in the bone. Why? To make the skull light. The main function of PNS is the same thing, to make the skull light, isn't it? And T4 means there's an intracranial involvement, cranial nerves involvement, intratemporal fossa and hydropharynx. Now, TNM staging, N is no evidence of regional lymph nodes involvement. N1 is unilateral, N2 is bilateral. Both the supraclavicular fossa involved and less than 6 centimeters. And 3 means more than 6 centimeters involved in the supraclavicular fossa. Now, the supraclavicular fossa is also known as hose triangle. HO apostrophe as hose triangle. Let me give you this brief idea over here. So see here, B is actually your lateral aspect of the clavicle. A is your middle aspect of the clavicle. And C is actually a midpoint that joins the neck with the shoulder. So when you just make a triangle, this is known as a hose triangle. Okay. So M0 means no evidence of distance Mets. M1 means distance Mets is present. Now this is very important. See. So stage 1, stage 2, stage 3, stage 4. T1, T2, T3, T4. N0, N1, N2, N3. M0, 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 M1. Okay, in that way. See here. T1 means T2, T3, T4. N0, N1, N2, N3. M0, 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 M1. So if you have much more confusion with this TNM staging, just repeat this video 1-2 times more, we will get it. Okay. Differential diagnosis is, of course, juvenile nasopharyngeal angiofibroma, rhabdomyosarcoma, lymphomas. Okay, now let's talk about the treatment options. So, what is the treatment? How can you treat the condition of nasopharyngeal cancer? So, see, there is radiotherapy. The first modality is radiotherapy. Do not write surgery in the first modality. Okay, first modality is radiotherapy. Then you can go for brachytherapy. Then you can go for chemotherapy, surgery, or you can go for immunotherapy against HPV or vaccination of immunotherapy against EBV and vaccination against EBV, and that's the experimental component. Now, teletherapy or external beam radiotherapy is actually you're giving radiation to all this area. So not only nasopharynx but also the surroundings or surrounding structures like your vagus nerve, which is supplying your, at the area of larynx is involved. Maybe your carotids may be involved. And that will lead to not a good prognosis. So it's absolute now. External beam therapy is absolute now. You have brachytherapy, and brachytherapy means you have interstitial or you have high dose, okay, or you have intratumoral. Okay, so what do you do in interstitial? You just go and keep that radioactive substance inside the tumor. Okay. Second one is you just keep some that radioactive substance in a probe and then you insert it. Okay. And 3 means high dose means high dose D you are giving that radiotherapy just to the tumor, Okay. And that's the best. Chemotherapy is cisplatin and 5-fluorouracil which you can use. And this 2 chemotherapy is actually very much applicable if in the case the tumor is if it's a recurrence, because there is chance of recurrence. Of course, there's chance of recurrence. Surgery you can opt if in case it's involving skull base or vital involvement. It's a big thing to talk about surgeries in UG talks. So on PG or moreover head and neck specialization component. And you can go for immunotherapy and vaccination. We won't be discussing more on this. Majorly it's 4, and we'll be discussing more on the brachytherapy because this is a more used advanced treatment. So external beam therapy, I told you that nasopharynx, skull base, upper neck, sparing the temporal lobe, pituitary and spinal cord, one anterior field, lower neck, sparing spinal cord and larynx. So whatever is written here, it's written. The most important thing is external beam irradiation is not used now because this leads to damage of the surrounding structure. So what we practice now is the brachytherapy. So brachytherapy is used for small tumors, residual or recurrent tumors. Small, residual, recurrent tumors. Interstitial, radioactive substance source, that is radium, iridium, iodine and gold, is inserted into the tumor tissue. Intracavitary means radioactive source is placed inside a catheter or mold and it's inserted to the nasopharynx. So I told you, intracavitary, you just keep it inside some probe. Probe is that catheter or molds, okay, some device, and then you just insert it into the nasopharynx. And one is high dose rate. High dose rate means high intensity radiation delivered with precision under computer guidance. Okay, so high dose of radiation is given just to the area of the fossa prosopon, just to the area of the tumor. Okay, it's highly practiced. So one is interstitial, intracavitary, and high dose. This is interstitial. Then you have intracavitary. This is intracavitary. This is high dose brachytherapy. This is very much practiced. Okay. Chemotherapy, cisplatin and 5-fluorouracil in irradiation failure and palliation in distance flight. So in the case of recurrence also go for brachytherapy, and if in case you need it, go for chemotherapy. In the case of radiation failure, you go for chemotherapy. Surgery, okay, so surgery you can go for, just know the names. Nasopharyngectomy, radical neck dissection, palliative debulking, malingotomy and groin insertion in the case of otitis media. But this is actually not a curative one. Okay, this is just supportive to just cure your conductive hearing loss. But other ones, main is nasopharyngectomy. You can go for cryosurgery, okay, for residual or recurrent tumor. You can go for radical neck dissection for radial resistance, lymph node metastasis, right? So a tumor is radial resistance and there's lymph node involvement also. How much radiation you give, there's no benefit. Go for radical neck dissection. There's a picture of radical neck dissection also there. See, this is a radical neck dissection. And after radical neck dissection, go for interstitial brachytherapy. That means you're going to give tumor, that is iodine or iron. Okay, this one. See, radium, iridium, iodine is you're giving inside the tumor tissues. Inside the tumor tissues. This is interstitial. Okay? You need to know the names. Radium, iridium, iodine, gold. Radium, iridium, iodine and gold. And intracavitary means you are keeping something inside a mold or inside a catheter and then you are applying it. Intracavitary. And high dose is this one. So radical neck dissection along with lymph node metastasis, along with this one, interstitial, we can go for in the case of radioresistance or electron deaths. We can go for palliative debulking and managotropy and gluten expression. So prognosis wise, stage 1, stage 2, stage 3, overall prognosis is good. There's a hydrogen because it's a radiosensitive tumor, right? So WHO type 2 and 3 carcinomas have good response to radiotherapy and better survival rates. 5-year survival rates, see stage 1, stage 1, it's very okay, 95 to 100%, stage 2 is 60 to 80%, stage 3 30 to 60%, stage 4 is 20 to 30%. So before this slide, thank you. I just want to add upon a summary. Okay, summary. So patient presents to the department of ENT with a neck mass, and he complains of hearing loss from one side. On doing your release test, you found out that this is a conductive hearing loss. You found out that this is a conductive hearing loss. That means your air conduction, it should normally, your air conduction should be more than the bone conduction, but here the air conduction is less, that is the lean is negative. So they won't be this much of explanation. Just they will say that conductive hearing loss was done, conductive hearing test like release was done, and it came to be negative. Weber's test was lateralizing towards the abnormal air because of masking effect. You know that, right? Weber's test. And on examination, he has the ear fluid level on his tympanic membrane. He has a neck node mass. On examination of his nasopharynx, you have a mass. What is the first step of investigation? So what was the first step of investigation? It was nasopharyngoscopy. Just go and look at the nasopharynx. If you can't see anything, what do you need to do? You can go for biopsy. Okay, blind seeing biopsy. You can go for, if neck nodes are involved, neck nodes are becoming larger, just go for an FNAC. What's the most relevant treatment? Very good treatment is radiotherapy. Because it's a highly radioresistant tumor. Okay, and stage 1, stage 2, stage 3, stage 4. Which has the best prognosis? Stage 4. If the tumor is highly radioresistive, you have to go for treatment. You can go for nasopharyngectomy, you can go for cryosurgeries, you can go for radical leg dissection. And what you will do with radical leg dissection? After radical leg dissection, you will go for radiotherapy, interstitial radiotherapy, like you can see in this picture, right? You can go for chemotherapy like cisplatin, okay? Which is the most common virus associated? Epstein-Barr, papilloma, Norvac, polio. So it is Epstein-Barr virus. So, okay, you have to take mark on Epstein-Barr virus. Question comes: which is the form of anaplastic type of nasopharyngeal cancer in topologic grading? 1, 2, 3, 4. There is no 4. It's 1, 2, 3. Out of 3 also anaplastic is 3. One is keratinizing, 2 is non-keratinizing.